I just want to say thank you for inviting me back here to Ontario to be able to speak about the BC healthcare system. I did have the pleasure of working for 3 years in the Ontario healthcare system. It was very purposeful. I came because I wanted to understand what Ontario was doing. And one of the things that I can share with you for sure is that I learned a lot when I was here, and it was the best 3 years of my career, actually, in terms of the great things you're doing. The first thing that you're doing, I think, very, very well, and you may not realize it, is quality. The focus on quality is alive and well in the Ontario healthcare system, and so that's something you really do want to hold on to. And I'm talking about quality in all arenas, not just acute care. So it's something you really do want to hold on to. My presentation today, and I've got a fair number of notes because some of it is the historical context of where we came from in BC to where we are now, and we're still on that journey, is it's a bit complicated, and it was a great walk through memory lane because I actually did live through this, and we talk about it being chaotic and everything's changing, absolutely, and we're just about to go into that again, and I'll share a little bit as to why very shortly. But it was very chaotic. There wasn't a period of stability. It didn't feel like it because for a period of stability you need a few years, and it felt like that there wasn't a lot of that. But one thing you all know is that change is part of healthcare, and if you're going to be a leader, you've got to be used to change in healthcare. That's just almost your middle name going forward. And so, as I said, very much still on this. But I thought what I'd do now, let's see if I can make this work. Yes. Is just start with the beginning for BC. So prior to the 90s, we had about 700 apparently different boards and organizations across BC. And when you look at the size of BC, we're very different from a population than Ontario. So that was a fair number of very separate siloed organizations. And then in 1990, the Royal Commission into Healthcare and Costs was commissioned, and the government of the day wanted to find out where are the healthcare inequities, and we needed to create an integrated healthcare system. So a lot of the words I'm going to use, you've heard them all before because this is the goal all the way along. So they brought forward, as a result of the report, new directions for healthy British Columbia. And the vision for the new directions was healthy citizens, healthy communities in BC. And its mission was to promote and provide for physical, mental, and social well-being of all British Columbians. Some pretty basic key priorities: better health, greater public participation, bring health closer to home, respecting the care provider. And to do that, we went down to 20 regional health boards and 82 community health councils. And the government expected these health boards and health councils to work together to design and plan, and they assumed that the boards and councils could actually take that jurisdictional responsibility and come up with a plan. And by 1996, we had a different government. And so does this sound familiar at all? I don't know. And the minister at the time announced nearly 2/3 of the 82 health councils and half the regional boards under new directions would be scrapped. And under the new directions, the local governments had too many, there were 2 layers and it was confusing. Nobody really knew what each other's role were, and that it was competitive and inefficient. Something that could happen here, as I'm listening to the setting up of the health teams. You could become competitive and inefficient, and that would be a real shame. So we went for better teamwork, better care in 1997. And the goal was to improve health care for people, again. And the priorities were ensuring access to the service you need when you need it, providing the best quality of care, keeping hospital lengths of stay as long as needed, but no longer, keeping wait lists as short as possible, and encouraging providing innovative new services, ensuring patient satisfaction, and ensuring that we make the changes that keep the public health system affordable. Again, pretty well motherhood statements. Oops. So the transfer responsibility occurred in 97, and we reduced the regional health boards from 20 down to 11. And we took the community health councils from 82 down to 34. All of this was mandated. There was no discussion. There wasn't an opportunity to submit and make a submission to self-form. This was all very top-down. And if you think about healthcare and how it was structured during those times, and many of you remember living through it, there wasn't an opportunity for partnership or collaboration. This was ministry-mandated, top-down approach. But just to make it more interesting, we also introduced 7 community health services societies made up of members of the community councils from within your region. So these health boards, health councils, and community services societies had responsibility for about $4 billion annually, which was about half the Ministry of Health budget. So the regional health boards were responsible for acute care, continuing care facilities, long-term care facilities, and community health programs, which was basically everything. So this is just a little map of BC, very different, but very much the same. Then you add in the 34 community health councils. They were responsible for the clinical delivery of care and acute care, continuing care facilities, and home support agencies. And then we add in the 7 community health services. And they were supposed to provide community health programs to the areas across BC. And then we had another report. The Auditor General's report, which was really interesting because I remember when this came out, but what I didn't remember was the timing. So only half of the transfer and responsibility to these new boards, councils, and societies had happened. And the government of the day decided to do a report on how well it was working. And the conclusion they reached is the regionalization process is complex and will take a long time to implement fully. I seem to remember that perhaps on another presentation here. So they did realize that, and that there was gaps in what was happening. The government had not clearly articulated its vision and its strategy. Therefore, it was making it very hard for the organizations to actually understand what they're supposed to be doing. The government had gone from a population-focused approach to healthcare to really more of a health services provided to the people focus. And that wasn't clearly articulated and made it very difficult for the leaderships of the different councils and societies to do this. And that the ministry needed to develop a strategic plan so that the others, the health authorities or health boards and councils, could then draw from that to develop their own strategic plans. And that really hadn't happened yet. Not surprising, we were only halfway through. Roles and responsibilities were also very confused. So what was the role of the ministry in decision making? What was the role of the health boards and the health councils, and then the societies? And there just wasn't a lot of clarity around that, and it was creating, just even with half of this passed over, some real problems. And lack of clarity around who was planning for responsibilities. And I think probably the most important thing, and at least it was for the ministry of the day, and I found it interesting, is how boards were selected did not necessarily mean that the people selected to those boards had the skills and abilities to actually be able to govern the areas that they were working for. So they needed to be looking at better knowledge, other attributes of the board members. And finally, performance measures really weren't there. But if you don't have a strategic plan, you don't know what your role is, and you're trying to figure all of this out, it's not a surprise that it wasn't working all that well. So this is what it felt like. And I thought I'd leave this slide for you now in Ontario, because this is what it's going to feel like for a little while. It just is. There was a lot of churn. There was a lot of uncertainty. And if anything, this iteration increased the divide between acute and community. So I bring forward cautions and to see if any of this resonates. Then the new government came along and with the change, and we introduced in 2001 one of the most, that government decided that the previous model was the most complicated and expensive in the country, and it was inefficient and ineffective. We knew that. So then they decided to move forward, and it announced that the 52 existing health authorities would be merged to form a new governance structure and management structure. So we've gone from 52 down to 5 health authorities. So 5 health authorities for a geographically spread out province with not as large a population as Ontario was a bit of a challenge. But I'll try to walk you through why they seemed to think it made sense at the time, and then what the implications were for Vancouver Coastal Health, which is where I work. So we have the Island Health, which makes sense. That's that little island there. That makes sense. We have Vancouver Coastal Health, which is the yellow and yellow. Notice how we're divided up. We have Fraser Health, which is the big skin cone one over to the right, or the blue one actually, sorry, the blue one. We have Interior Health, which is the skin tone one, and then we have Northern Health. So it made sense at the time, but just to make it interesting, we added 15 health service delivery areas as well, which really looked at the geography, and it also looked at what the patient and physician referral patterns were. So because Bella Bella and Bella Coola, which are in the northern part there of Vancouver Coastal Health, the referral pattern was to Vancouver. They decided that they would bypass Island Health Authority, Fraser, Interior, and Northern, and they put them with us. So as the Chief Operating Officer for Coastal, which has Bella 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 Coola, I spend my time in 12 to 16 seater planes a lot, flying up and down, because it's about an hour, hour and a half flight. If I drove to Bella Coola, it would be 13 and a half hours. And I can't drive to Bella Bella. You can only go by boat or by plane. And it's a 99.9% Indigenous community as well. But at the time, this made sense. So the 15 health service delivery areas, which are within the 5 health authorities, are to deliver health services, meet the performance objectives, and ensure community input into health service planning. But we're not done. We also had denominational agreements with two faith-based organizations. So within Vancouver Coastal Health, we have Providence Healthcare. And based on the agreement with the health authority and the government, they have their own board and CEO that helps to operate there. And they have acute care facilities, residential care facilities, and that is it. They don't do public health, they don't do community services as well. So but we are the flow through of the funding for them. So you can imagine the tension that happens with that denominational organization at times. And then we also, in Bella Bella and Bella Coola, had United Church, and they've since pulled out and transferred all services over to Vancouver Coastal Health. So within Vancouver Coastal Health, it's large, and it's like a big elephant. It's a makeup of at least 10 acute care facilities, at least 6 urgent care centers. How many of you have ever been to Whistler? How many of you watched the Olympics? Okay. We have a 18-hour facility that's open there, but it's urgent care. So we have at least 6 urgent care facilities. We have 21 community health centers. We have 19 assisted living, some of them owned and operated, some of them are contracted. We have many residential care facilities. And across BC, just to give you an idea, I know here in Ontario you don't own and operate long-term care, but we probably about 65% across BC are contracted, and the rest are owned and operated by the health authorities, the various different health authorities. So Vancouver Coastal Health has just over 15,000 staff, about 5,500 physicians. Most of them are fee-for-service, but there are some that are salaried. And the salaried ones are usually in the tertiary or quaternary. Now, do you have quaternary centers here, or do you just call them tertiary, correct? But you do have quaternary, okay. I thought it was something we just made up in BC, actually, because I didn't hear it when I was living there. We serve about 1.25 million residents, which is about 25% of the population in BC. So big geography, but small number of people. And the actual square kilometer of Vancouver Coastal Health is 50,000 kilometers. But we cover 12 municipalities, and we have 14 First Nations within BCH, 13 of which are in my portfolio, which is coastal. So when we talk about those HSDAs, those evolved into, they were geographically set up, but we call them now communities of care. So my portfolio is a compilation of 6 different acute care sites, many long-term care sites, and we do everything from public health, home support, home care, resident, assisted living, long-term care. What have I missed? Trying to think now. It is the full gamut of care. So from end-to-end care is provided through Vancouver Coastal Health, and there is very little that isn't in-house. As I said, long-term care is probably the biggest one. We did for a period of time have home support contracted out, and I'll get to what's happened with our change of government. Then, just to make it a bit more interesting, except I can't make it work. The wheel's not working. There we are. We had Provincial Health Services Authority. So when you talk about your one governing body, this is what PHSA is to us, but it's a little bit different. We do have BC Cancer Agency, BC Renal, many of the provincial types of services, but also BC Ambulance. We have one ambulance service for across the province. So again, it is a little bit different. But they created PHSA because they wanted to make sure that health authority would contract from a performance standpoint and provide the funding to ensure that the specialized services that were required across BC were actually being done in a fair and equitable manner. Now, the interesting thing about PHSA is it is a funder and a coordinator of specialized services, but they also have BC Children's Hospital, Women's Hospital, and the Cancer Agency as well within. So they are actually an operator, but also a funder. So it is an interesting health authority, and they're about to become something even bigger than that. So what changed for us? Well, the boards were gone. The government appointed the board chairs and the directors. And with our new government in the last couple of years, we've also now got new board members and new board chairs coming forward as well. There was performance contracts which were created for the health authority. And the health authority was then mandated to work with their different HSDAs or communities of care, whatever they call them, to actually ensure that clinical services and the measures within those performance contracts were met. And it was very clear what the role of the ministry was and where they fell in with health planning. We didn't have any problem understanding that anymore. But it was very much a unidirectional at that point in time. And we also introduced Bill 29 and Bill 94. And Bill 29 gave the employers the ability to contract out. And Bill 94 changed the language around employment security for employees as well. And these two bills, if you've been following BC News at all, have just been recently repealed, and I'll talk a little bit more about that. So now, just to go back to the accountability part, there's a mandate letter that comes yearly, and then there's a bilateral agreement that's also issued as well, and we meet quarterly directly with the ministry at the health authority executive level. We meet with the ministry to find out where we're going. So there's no in-between, it's you and the ministry. The other thing that's happened is the creation of First Nations Health Authority. And that adds a new level of accountability to BC healthcare that we have not previously had before. And it's actually one that I'm very excited about and also think it's been a long time in coming. So we are the only province in Canada to have First Nations and our Indigenous peoples recognized as having unique and special health needs and the right to have decision making But I want to be very, very clear when I'm doing this presentation, because this is part of what's so important, is I don't represent First Nations Health Authority. I don't represent First Nations, and I can speak to the governance structure and what was put in place and the history of it, but for me to speak at all about the effect of colonialism and the impact on the patient experience when they come through the door, and the need to design and plan differently, that would be something where you'd really want to invite Joe Gallagher, the CEO of the First Nations Health Authority, to speak. And I don't know if any of you were at the Ottawa NCHL conference when he talked about the impact for Indigenous people. He's a great speaker, and he's very passionate, and he's one of the smartest people I know. So First Nations Health Authority was created 10 years after we created our health authorities. And it really came together with BC First Nations Health Council, BC First Nations Health Society, and this was going to provide province-wide delivery of health services and take it from the federal government, because as you know, the federal government is responsible right now for delivery of funding for First Nations community. And it really gave the power and accountability to the First Nations people. But it also made the health authorities much more accountable in how we work in partnership with them. So we signed a BC tripartite agreement, and it has expectations going forward, and it's not small. So one of the things that would be different, just to give you an idea, is I would never start a talk in BC without acknowledging the unceded territory or lands of the different First Nations that I work on. We would never plan a new design without making sure that we had the First Nations at the table and in true consultation. So the First Nations Health Authority established May 28th, 2012. It was pretty exciting. So before I came, I ran this presentation, as part of the presentation by the Executive Director in the First Nations Health Authority, really trying to make sure that I was, one, not representing anything that didn't make sense or that I was representing them in the wrong way. And one thing she said to me is, you may get a question, Karin, asking you, what does it look like to work in true partnership and collaboration? And I said, oh, Kim, I can tell you what it looks like when you don't. We recently had up in one of our northern communities, the idea that we would redo the staffing model and that we would decrease the care aides and increase LPN, and which RPNs here, and RNs, because the acuity of the care was going up, and we felt it was a good thing to do. And the director went over and talked to the band and council, just told them about it, and they didn't say much. And there was a health council as well in each of these communities. So we went and talked to the health council, and they didn't really care because they were responsible for delivering home care and home support. What we didn't take into account is that these care aides were people who worked within the community and lived in the community, and they were First Nations. And they were that cultural link for the residents, because we had long-term care in this facility as well. They were the elders, and they were the knowledge keepers. So it took less than 3 weeks for a letter to come from the chief. It took even less time for the Grand Chief to send a letter of protest. And First Nations Health Authority just sat back and watched it happen because they felt it was probably going to be a good lesson. And the board director, he was just about out of his mind with this, and I said, stop. Because what they said, and it was very true, is we had not really adequately consulted with them. We told them, and they didn't say anything, so we took that as it's all fine. It wasn't. So I just last week wrote a letter, a year and a bit later, apologizing, asking for permission to go in front of Chief and Council to talk about how we can repair the damage. So it's not a small thing, what we have to be doing and thinking about. So that's what it looks like when you really screw up. The important thing about First Nations Health Authority is it doesn't replace the work of the health authorities, and it doesn't replace the work of the ministry as well. They also have an accountability letter as well, and a mandate letter as well, but they're very, very important partners with us. So this is BC again, and on this map, it's almost impossible to show you all 13 of the 14 First Nations that are clumped into my one little area there. But each community, and this is important when dealing with First Nations communities and Indigenous peoples, each one is like a different country in Europe. One is not the same. You have to approach, and if you went into Europe and said, well, we're all going to do, each country would just have a meltdown, a nuclear meltdown, but their health needs and their inequities and their desire to be involved is very different depending on which community you're in. And the one thing that I've learned that's so important is to come in and ask, where do I fit? Versus, this is what we can give you. And that's part of, from the top-down component of what the ministry is trying to get us to understand with this. So the mandate letter explicitly outlines what we need to be doing and how we need to be with First Nations Health Authority. It explicitly tells us that we have to have shared decision-making, and that goes right from service planning to the delivery of the health services. Each health authority also has to have an Indigenous health plan. So within Vancouver Coastal Health, we have a department or a program that's Aboriginal health. And it has Aboriginal health patient navigators. There are peer support workers. And I don't know if you've heard about our opioid crisis in Vancouver. We have a large number of offers of Indigenous peoples living in Vancouver, and so we've hired a significant number for the downtown east side of Aboriginal peer support workers to ensure that we are giving culturally safe and appropriate care. But central to everything is making sure that we are systematically embedding cultural humility and cultural safety in everything we do. And I can't emphasize enough how big a deal that is, because it really does require you thinking differently than what you did before. The CEOs and the CEO of the Health Authority and the Ministry have signed a declaration of commitment, and it embeds cultural humility and safety right into every aspect of health service delivery. And culture and safety are considered as essential dimensions going forward. We're about to put up a new tower at Lionsgate Hospital, which is one of the sites that I manage. And we've had to stop until one of our First Nations communities can actually come to the table. They've had elections and they've had some deaths in their community, to be able to provide their input into the design before we can move forward. It's not bad at all, but it means that you have to start planning out a little bit differently and making sure you've built that relationship long before you're starting to build a building. And so that you are very close and you understand what the needs are of each one. Cultural safety, we spend a tremendous amount of time and energy with all of our employees, so 15,000 employees, 5,500 physicians, all are expected to take an Indigenous cultural safety program. And there's a couple of ways they can do it. You can take the PHSA online 8-hour course, which is actually not a bad way to start. I call it a primer, really, where you learn that Christopher Columbus didn't really discover a country that already had 1 million people in it, for example. But it also talks about when the last residential school closed, which was in the 90s. And it gives you the perspective of what the impact in terms of how Indigenous peoples actually approach healthcare, whether it's in the community or it's in acute care, or even when it comes to placement in a long-term care facility, what that looks like for them based on years and years and years of colonialism. So this is just the spectrum of where we are in terms of building cultural awareness, sensitivity, obviously, cultural humility, but cultural safety is our goal. And it's really a process of making clinical and structural changes to get the outcome for Indigenous peoples to feel safe and receive quality of care. So we are opening up an urgent primary care center as part of our redesign of our system. And one of the things that we are doing is making sure that we have elders in the as part of the care team, the ability for smudging, the ability for alternate types of medicines as well in this urgent primary care center, because it's right between two First Nations communities as well. And so that's what they've asked for, and that went into our service plan to the ministry. So it's not a small thing, and I happened to have run away to Ontario when this was really just coming together. So when I came back, it was quite amazing what the expectations the ministry had put on. And we actually now, within our mandate letter, will have the United Nations Declaration on the Rights of Indigenous People built into our mandate letter with expectations associated with that. And it's not wrong. We haven't done a good job of creating a safe environment for First Nations people to come into, from the emergency, as I said, public health, you name it. We haven't really done a great job. So that brings me to what works. So in terms of the healthcare system in BC, I just want to be really clear, we haven't got it right yet either. But we're not one big health authority like Alberta, which maybe they are still. And we're not 140 hospitals trying to come together with community public health and long-term care like you are. But you're poised, and just listening to what you've talked about here, you're so poised to do it very, very well. The one thing I will tell you that works is really the coordination. All of the services fall under one health authority now, or the 5 different health authorities. But when you're trying to make big change, or just make change and standardize, having that coordinated under a health authority is very helpful. And then there's the board, there's the senior executive team, and then our communities of care, or HSDAs. It's pretty simple. There's one person steering the ship, actually. The accountability is clear most of the time. Did I mention we have a new government? A new government. And the directions set out in the mandate letter, bilateral, and it's easier in some way in what you're doing right now. I will say it's a bit easier. Standardization is something that I think has helped and harmed us as well. We have a large IT system that we, between PHSA, VCH, and then the denominational Providence, we're putting Cerner in across all 3 organizations. That's going to cover about 20,000 employees. And from Vancouver all the way up to Bella Bella, they'll be on the same chart. It'll be one chart, one patient, one chart, which will be great. Now I want you to think about taking 3 large organizations and getting them to standardize their charting. And it comes down to, is it blood pressure, pulse, temp, certain saturation, or that's not how we do it. And 3 organizations that probably haven't worked all that well together are health authorities that haven't worked well together as well. So it's taken many years. We were supposed to be at HIMSS level 5 in 5 years. Started in 2011. And in coastal, a couple of my sites have just gone live. So it's good for the patient in the end. And that's one other thing that BC Ministry did very well. They said you have 2 IT systems that you can pick, Meditech or Cerner. That's it. So it was helpful because that decision was taken away. We knew pretty well it was one or the other, and went off to look at that. But it is also, it takes more time, and it can be challenging. Also, with procurement and shared our services, we went to BCCSS or HSSBC. The acronyms will kill us all yet, but the procurement choices and procurement process started to feel quite burdensome. We're staying with it. We are probably getting better pricing on a lot of our services and things, but it is challenging at times to understand it if you're in a small rural site, why you have to go through, or a remote site, through HSSBC to get a product that you know that you're only going to use one of, and they come in hundreds. The budget transparency is much, much better. So the budgets are rolled up under the health authority on a period basis, just like here, but you see across long-term care, across community, public health, acute care, all of it is visible to everybody on a period-by-period basis. So everybody knows who's spending what, and there's no sock drawers. You can't hide anything anymore. And I think is good in that respect. It's also a large amount to keep track of. The other thing I think that's important is access for rural and remote and the visiting specialties. That is much, much improved. So we have telehealth in spots and pockets. You're doing it much more here. The OTN, I wanted to take OTN back with me to BC. We actually had them come visit. Because you actually do have something that BC doesn't have, which is the spine part. But in Bella Bella, we have 23 telehealth clinics that we run, and we have a lot of visiting specialists. We were also able to standardize across BC the life, limb, threatened organ transfer using BC Ambulance, and also our patient transport network as well. So those are things with health authorities that we were able to do. Nobody could opt in or out. It was mandated down. The other thing I think that this has helped, and it's taken a long time, is improving the relationship with primary care. In BC, we disenfranchised our primary care physicians. They left the hospitals. They were no longer feeling welcome for many reasons, and the fee structure did not help. But the ministry's put a lot of work into bringing primary care back into the fold, and you are miles ahead here in Ontario with the work that you've done with primary care. It may not be perfect, but it took a lot for us to bring primary care back and build that trust again with the ministry, but also with the health authorities. Something as simple as, I used to have free parking. Now I know parking's a big deal here, because God knows when I was at Grand River, that's all I seemed to deal with was parking issues. But that was a big deal for those physicians. They really felt that they weren't valued anymore. And with this, it's made a difference. So the two groups that probably felt the least involved and had the least amount of voice were primary care and First Nations. They're at the table now. And that's very, very important on a go-forward basis. So lessons learned, you've already put quite a few of these out already. We're 18 years into our configuration, and I would say the first 10 years were brutal. They just were. When you think about Powell River, which is one of my sites, is two ferries or a plane ride away, who had, in their mind, a referral base with Vancouver Island, and they never see anybody anyway. Why would they want to be part of VCH? Why do they have to ask VCH? Why do they have to, when they want to credential their physicians, have to go through VCH? The further away you go, the more rural and remote, the less people feel connected. And that is something that we've been working on for the last 8 years very, very actively. But this was a forced integration. There was no choice on it, and it was ministry mandated. And so that created right away that loss of autonomy feeling. And we didn't even use the words change management at that point. I mean, there wasn't a lot of investment in change management in those days, if you think back. You're in a different spot. I'd say the biggest thing to do with this from now on, and I know you're doing it here amongst yourselves, but with your physicians and staff, and do not underestimate the power of upset physicians and staff, is you communicate, and then you over-communicate again. Even if you don't have anything to tell them, just communicate that as well. We don't know, but as soon as we know, you'll know. I think if you are designing and pulling things together without them involved, you run a real risk of spending years trying to bring them back into the fold. The other one is taking calculated risks. And so that's that talking about you have to spend a bit to actually make a difference, and it's not a bad thing. We had a CFO that came, he probably was about 2006. So we'd been into this for a while, and we'd run ourselves into quite a large deficit. And he came in, a South African fellow, and started investing in very, very careful ways. So across all of BCH, he is the CFO. And he invested in technology. He invested in workflow changes or new ideas if they could show the return on investment. And he's probably one of the smartest guys that as a CFO, bean counter as I call him, I've ever met. And the things he invested in, sick time and overtime reports. Managers are so responsible for sick time and overtime. That's one of the big things we hold them accountable to. And yet they wouldn't get the reports until the period had closed. That horse was out of the barn. You weren't even seeing dust anymore. They were so far down the road. So he created a new automation, or had them create a new automation where the managers could actually go in and pull the reports, or have them pushed out every 2 weeks. So in order to help people do their jobs and be more efficient and be more accountable, he created those types of things. For Lionsgate, when I was the director at the time, he did something a little bit different. He actually made me do something I didn't want to do, which was introduce predictive analytics to the system. We'd just gone through going from a paper-based staffing schedule to electronic chronos, and we were still reeling from that, and he said, well, it's your turn now to try this. And it looks at 3 years of analytics, or of ADT data, puts it in through an algorithm, and then will predict how many patients are going to come in and what you need to have for your length of stay, and how many discharges you have to create in order to be able to maintain your capacity. So these surges that we all have, and we are so surprised when they happen, it predicts that. So then you can staff up on straight time because you know you're going to have to, but you also know when you can staff down. So it's good for closing beds and opening beds, but you also need to know where your staffing's at as well. And in the first year of putting it in, I went from, in my portfolio, a $900,000 deficit, which was big at the time because we have to meet budget all the time, to a $1.1 million surplus the next year. What was more important is he said, okay, that's great, you have a $2 million shift. What you're going to do now is take that million and you're going to invest in something that will make a difference. So we invested it in patient beds. The reason being, every single staff member and physician could relate to us investing back into patient beds. Rolling stock is not something that gets a good investment, so we rolled them out and the staff got it. It was one of the best forms of communication for the staff as well, but also even the community staff were very, very invested in that. Let's see the other one. Be prepared, or build the system integration at all levels early and purposefully. I don't think we did this very well. And you're here today and you can actually do this in a way that makes sense. We didn't have time. It was within a couple of months that we were 5 health authorities. And so we've struggled as to what that looks like, and we've gone through different iterations from having an acute care network, a primary care network, and a community care network, and they were kind of in concentric circles with the different populations running horizontally that everybody was supposed to be serving, and that didn't work. Really what we needed was the regional councils looking at the services and have them connect, and that seems to be working a lot better. The one thing that I talked about, but I do want to just emphasize, is no matter what happens now, people are going to feel a loss of autonomy. And that's not something to minimize. There were many independent hospitals and boards, and people worked for their hospital. They didn't work for VCH, they worked for their hospital. And so just because you change the geography or you change the governance structure does not mean that for everybody they're going to say, gosh, now I'm glad we're VCH. That piece will take some time. The decision-making changes. For the physicians, it was especially difficult because they used to be able to go up and talk to their board chair, and now that wasn't available. And even for the community, it was very difficult for them as well. And I would say there's still some outright resentment about the whole thing. I call them my Wild West sites, where you go in and no, what is one of the military VP leader, says you feel a little bit like the Taliban. They're just sitting there waiting. They know you're going to come and go, and if they just kind of stay low, they can go back to what they were doing before when you go in. He says that they're not really going along with what we want them to do. So we have to engage them differently. The other thing is patients as partners. The role of patients in redesign wasn't even considered, really. We were just going to make it better for everybody in the province. But the role of actually involving patients in the redesign, it is something you can do. You could actually bring patients into your redesign and be part of your submission, actually, because who better to actually have that discussion and give input than the patients themselves. I heard you say, we need to make sure that they're better educated. You're absolutely right, but we need to be better educated as well. And sitting on the other side as a secret shopper is an eye-opening experience for any of you that have had loved ones go through the healthcare system. We have a lot to learn from patients, so I would definitely encourage you to bring patients and staff along with you on this journey. And then finally is learning from others. It's really, really important, and you're doing that today. I'm not sure I'm sharing anything that's new, but you've been hearing what's happening in the States. Everything that you talked about can be done up here. And it's approaching it with how could we versus, well, we can't because. And healthcare, I think sometimes just because we're so chaotic, we start with we can't because rather than what will it take. And a lot of what you're doing, we're doing already in BC as well, but we're calling it something different. So it is possible to take what you're talking about, including incentives, and change it. Now, things that aren't going to change, at least in BC for a long time, is fee-for-service physicians and a cost-constrained healthcare system. So there's always going to be some tension there for sure. But we're doing some great things with primary care, for example, and they're at the table and they're interacting with the ministry versus going through the health authority. So I think that helps. But look to other provinces, NHS, Denmark, Sweden, and remember, no one size fits all. You have to kind of figure out if it's going to work for you or not. They're not bright, shiny pennies. Wow, that works. Let's just do it here. Be very careful about what you do put in, and be okay with failing. I think that's okay. If God knows when you look at BC, that's one of the things we did. We failed a lot in the first bit, but the other difference was for us and why we've been able to move ahead a bit more is we had the same government for 16, 17 years. Don't underestimate how important that is. We didn't realize how important it was until we have our new government now. We have a new one, and board chairs, as I said, have all changed. That's quite a change for us as well, and board members. The same chief from Bella Bella that I was talking about from Chief and Council, she's sitting on our board now. And that creates a whole new dynamic for inviting the Indigenous peoples into every single board in all 5 health authorities now. So their voice is very different there as well. One of the, where was he from now? Say the Mayo Clinic, Dr. Swenson. He came and gave a talk to us a little while ago about culture, actually, because this is something VCH is now trying to do, is rebrand and create a one VCH, because we know that our staff are feeling very disengaged. And he talked about something that I think you need to remember with redesign, which is called wide guardrails and thin rule books. And it just makes sense if you're going to do this. But I would also caution, don't try to boil the ocean and get it right first. You would be the first in the world to do that. But you also are setting yourselves up. So, wide guardrails, thin rule book, allows for that, for the creativity, and also to stretch out to that long game. And then for me, it's always ask yourself, how will it help the patient? And if you ask yourself that with every decision that you're making right now, and a patient, client, resident, I think it's easier to do that. And we'll cut down on the chaos and the lack of understanding from your physicians and staff as you're moving forward. Because don't fool yourselves, whether you're in the community, public health, which I understand is just a wee cut in the last little bit, and others, this will be chaotic. And they need to know that every decision you're making, you're putting it with the patient and the client resident up front. Just about done. So we're not done either. So we consolidated all of our backroom services in 2009. We took a lot of them, our IMETs, our biomedical engineering, pharmacy lab, DI, health records, all across 3 health authorities, or 4, depending on who was in, who was out, with the idea that we were going to save a lot of money, about $100 million in cost savings. And it was to leverage all the opportunities to create efficiency and create sustainability. So I call it the period of, I lost 3 months out of my life I'm never going to get back, because I had to help develop or evaluate the service level agreements of all 12. And I think we're down to 9 now, because 3 of them fell apart pretty quickly. But it has made a difference. Each health authority kind of owns one of those services and then contracts out. So it's complicated, but it in theory should work. But that's changing as well. Then in 2019, the new ministry introduced a new geography classification, which takes it right down to the community level of agencies. And those are called CHSAs. So they're community health service areas. And really what it's for is to help us with planning. But now when we're talking to the ministry, we're not talking about health authorities, we're not talking about HSDAs, we're not even talking about local areas, we're now talking down to a minuscule level, and it's becoming complicated again as we're starting to do this. It's good for planning for the different geographies, but it does make it difficult in the conversations. There's 218 CHSAs, by the way. So we're going back up the other way. Then we repealed, or the Bill 29 and Bill 94 were repealed this last year. And what that means is, and especially for most of the health authorities, when Bill 29 came out, we contracted out our food services, our laundry, our housekeeping. Those were the 3, and our security. With the repeal and an NDP government, this means, and there's an expectation, that we will look at bringing them back in-house. So we haven't done housekeeping, laundry, any of that for years. So the work that's coming forward on this, where we will, and the decision hasn't been made by the ministry yet as to which will come in-house and which won't. We've had a lot of consultation, which is great, but this is about to happen. But BCH and 2 other health authorities also contracted out their home support. And the decision to bring all of our home support services back in-house has also been made. And so we are now in the process of issuing notice to our providers and migrating home support back into BCH and Fraser Health Authority, and I think Vancouver Island is fine. So we are going through chaos. Please don't think we're sitting out there in the Lotus Land, sunny all the time. It's just great. We figured it out. This is going to create a high level of chaos and turmoil for people receiving this care. I feel very fortunate that I didn't get on the contracting out basis for home support, and in my area, which is coastal, they're all owned and operated with us. So we don't have to do that. But just with any good idea, they've decided, why don't we do a new model of care while we're bringing them all in as well. So when we talk about don't boil the ocean, this feels like we're just turning the temperature up. It's going to be hard enough to bring in hundreds and hundreds and hundreds, thousands of healthcare staff. And then most recently, I mentioned PHSA, and this is really almost to the very end here. The government has decided to have some of the services have a provincial oversight by PHSA. So medical imaging, pharmacy, IMITS, which is your technology services, are just a few examples of that. And there is a lot of tension and discussion going on about what that would mean for province, with the 5 health authorities having one centralized body of governance over those. We're not there yet. Stay tuned. I'm sure it'll be in the news, because sometimes the news actually comes over the mountains this way. I just know it does. So, I'm hoping that sharing my perspective, which actually was not grim, it really wasn't. Even in our worst, most chaotic time, the one thing that I found was there was an opportunity to be innovative and think about things differently. You weren't constrained by, we can't because you didn't know where the guardrails were at the time, but you also became much more innovative. And I will tell you, we became more efficient. We just did, because we had to. Our budget was our budget, and there was no leniency around. And for many years, there was a percentage being taken off. And we did become more efficient. We also became more efficient in acute care because we started to work with community. And I'm going to leave you with this because I think it's one of the most important things to think about, and we're still not there in BC. If you focus on your acute care and what's going on in acute care, like we did in BC for many years, you will never change your ALC rate. Never. I don't care how many beds you put in. Doesn't matter. You'll never change it. We are finally investing in community now. We're not investing in acute. We are investing in community. We're increasing the hours per resident day to actually put in enough support workers, but also allied health. We're investing in palliative care so that people can stay at home. We are investing in our home and community support workers so that when we say to a physician, it's that promise, that trust, that we can discharge them home 3 days earlier, and there will be somebody there, that there is actually somebody there. Because you all know that it takes one failure, and that physician's never discharging that patient again, and it goes so fast, right? And that's after years of, there was a home first, home is best, what I call stay home, go home, stay home. All of the different mandates that you go through. All of those different strategies didn't have the mandate of the funds going into community. So we were investing in the wrong end of the whole thing. Our long length of stay, when I came in 2016, before we started really looking at this, we had usually in a 285 bed hospital, we had anywhere up to 60 patients staying well over 1,000 bed days. We're down to 25 now and under 600, and some of those are mental health clients, which is difficult, and we need to build more relationships with supportive housing and so on. But it really was about people working together across the system. Community does not say we're closed, and acute doesn't say you're not doing your job. And it's working on building those relationships and looking at the long game, and always keeping the patient and client and resident in the middle there. So it is about the relationships. And one thing I will say, having just implemented this huge IT system, going from completely paper to barcode administration, closed loop med admin and all that, and it was a pretty big thing, physicians now having to work on computers, is that people will jump off a cliff for you if they know why they're doing it and they trust you. So building that trust is the most important thing possible. And that only happens by communicating and being very authentic and very transparent. So it's not an easy thing that you're about to embark upon at all. But if you can form those relationships and strengthen those relationships as you're going along by sharing and engaging people, that'll make all the difference in the world. I'm just going to close with, again, best 3 years I've ever had working in my healthcare career was working in Ontario. I worked with a very progressive and brilliant CEO, but also with a team that would work together within a LHIN. We almost functioned a bit like a health authority because the relationships at the senior level all the way down through were very, very good. Our relationship with CCAC at the time was very, very good. And it felt like we were almost operating like a health authority in terms of for the patient, they didn't know where the silos were anymore. And if you can do that and make it so that a patient doesn't understand there's a different silo or funding partner, you've made it. You'll get there. So thank you very much for your time. I really appreciate it. And I'm open to questions. Well, they're no worse than us, probably, in terms of we've got a ton of data. We're data rich, but what we do with it and, whether we reconcile it, that's part of the problem. With our new project with the Cerner implementation, just getting the ability for Indigenous people to be able to self-identify at the front and have that built in, it was easier to climb Kilimanjaro than it is to get that happening. That said, within First Nations Health Authority, they have built their own database. They are also working with all of their communities. I mean, a couple of the communities in my portfolio, you either helicopter or four-wheel drive into. And they have telehealth, but they've also created a data sharing opportunity within First Nations so that they're able to track the the population health of their different communities. We know that the health outcomes for our First Nations and Indigenous peoples is significantly worse. What we didn't know than the non-Indigenous, what we didn't know is in what communities. So they've been able to start tracking that. Where it gets more tricky is your off-reserve First Nations individuals. But when we started our opioid crisis in Vancouver, the First Nations Health Authority was actually able to provide very valuable data on who the most vulnerable individuals were, how many more Indigenous individuals were dying versus non-Indigenous in the city, because I mean it was amazing per day how many were actually dying. So to understand the impact on the community, certainly for that. So they are a bit more sophisticated, I would say, in what they're conducting, but they have within their authority their own data and decision support analytics group as well. I suspect it's through BC. There may be some federal transfer, but it most likely would be part of the transfer. The federal transfer came through to the ministry and then to First Nations Health Authority. Yeah. Yeah. And I don't even begin to understand all of the First Nations Health Authority. We do have caucuses, sub-caucuses, 3 of them within my area, and then those roll up into a large caucus. And I sit on the Aboriginal Health Executive Steering Committee as well, which then reports up to the Tripartite Committee, which then reports up to the Ministry directly. And the First Nations Health Authority also has their own reporting structure to the Minister as well. So what the projects we're working on are really exciting projects because it will shift what's happening in some of our more challenged communities for sure. My goal for one of the areas is eventually, because they're 99.9% Indigenous, is to actually see a self-governed and owned and operated facility that eventually we will turnkey that over to them for them to run. And there's examples of that in Canada. Not that I don't like the plane ride up to Bella Bella, but I could go without. We have. We've incented we've got a rural initiative, and we're actually, much like here, training rural family practice residency programs, and we've been able to populate. And they do offer an incentive to rural physicians as well. So that's made a huge difference actually going forward. But if I look up Sea to Sky Corridor, I have communities where Whistler, for example, has a real crisis happening because the family practices are closing because of the real estate prices. Our worst area right now for family practice and people being attached to a primary care physician is in Vancouver. Because it's very expensive. Real estate is very expensive to buy in Vancouver, and rental for the actual office space is quite significant. So that's where we're partnering with them in different ways to be able to create those patient medical homes of many physicians together along with NPs. We've also put NPs throughout BC a lot more, especially in our more rural remote, to help augment the gap in primary care. That's one thing we did very well. We disengaged them all. Now we've got to get them back.